Our next speakers will be Subul Bazmi, whom you've already heard from before. She's a consultant gynecologist and minimal access surgeon at Derby Endometriosis Center, and she's been involved with various prongs of this, including MDT. And we also have Mr. Simon Williams, who is consultant urologist and laparoscopic surgeon, and who's also the member of the Derby Endometriosis Center MDT team. He works closely with the gynecologist team for several cases. He's also a member of the British Association of Urological Surgeons.
Yeah.
Thank you.
Thank you, Nilofer. Guys, can everybody see my screen? Can see my slides moving? Just thumbs up sign.
We can see your slides.
Yeah.
Yep, go for it, Subul.
Okay, brilliant. So yes, that is the title of my presentation, and essentially we have had quite a lot of women who we have managed in the last. Has my presentation gone off? Oh, Joyce. Okay. Yeah. All right. So like I said before, we've had quite a lot of women who we have managed in the last year and a half who presented to us with ureteral endometriosis. So we then decided that we need to really highlight this abnormal feature of endometriosis, and then bring it to light and just see what our findings were. So we did a little a case series. So I would like to thank Mr. Prof Amir and Mr. Williams really for helping us out with this, and the entire endometriosis MDT team in terms of management. So basically, the urinary tract is the second most common extragenital system that is affected by deep infiltrating endometriosis, secondary only to the bladder. So the bladder, the incidence of endometriosis in the bladder is about 84%, and in the ureter is about 15%, which is 0.1 to 0.4. So total urinary tract endometriosis is between 1 to 5.5%, out of which a good chunk of it is in the bladder and then the ureter. Now, rare cases, it has been seen that it can involve the kidneys and the urethra. Now, the problem with ureteral endometriosis and why the interest has risen in this particular area is that when endometriosis occurs, there is inflammation followed by fibrosis, and then this unfortunately causes compression and distortion of the normal ureteral anatomy, resulting in hydronephrosis, hydroureteronephrosis, eventually loss of renal function, so on and so forth. Now, the ureteral endometriosis is asymmetric with regards to the side of the occurrence. However, quite a lot of series, systematic reviews, and literature reviews that I've done have shown that it is more predominant on the left side, about 80%, and 20% on the right side, and more common in the distal third of the ureter, just in proximity to the uterosacral ligaments. Now, there are two types of ureteral endometriosis that I have read about in literature. Quite interestingly, there's an extrinsic type and then there's an intrinsic type. The extrinsic type is the more common one, which involves the adventitia or the outer layers of the ureter, and then the intrinsic one is the one which is the more problematic one, which affects the muscle layer, the lamina propria, or the ureteral lumen. Now, patients with rectocervical endometriosis have got a 7-fold greater chance of having ureteral endometriosis, or there to be a spread of the inflammation and the fibrosis. Now, patients with rectosigmoid endometriosis, as you can see, have a 22-fold greater chance. The only reason I'm giving you these numbers and figures is for us to appreciate that if you see these lesions, please look and screen for the ureters and the kidneys, because there's a higher chance of it spreading and affecting them. Now, the case series that we did, we picked up 10 women, all with stage 4 endometriosis. Some were known to have stage 4 endometriosis, a couple weren't, and they were unfortunately the incidental findings. And they came to our unit. They were not our patients, were referred to our unit, and this was between early 2021 and late 2022. And the diagnosis had been made by MRI. and 2 patients had renal function tests which were abnormal and then went on to have imaging. Again, I'll just highlight what my aim is. Again, it's to let everybody know about this insidious disease resulting in disastrous effects. There's no current screening tool for patients with endometriosis to monitor the renal function, but having said that, I think, again, it is up to the healthcare personnel and clinicians to maintain a high degree of suspicion and approach women with severe endometriosis with caution, adopt a holistic approach, and look for signs, look for triggers that, could this, I mean, I'm not saying send every woman for a renal scan, but certain particular features, please have a high level of suspicion. I'll go into it later. Now, renal imaging is essential and should be done routinely, is what we do here in our endometriosis unit, especially in women with severe endometriosis. Concurrent risk factors like endometriomas, previous PID, previous rectosigmoid lesions, previous rectovaginal lesions, adhesions, have a high degree of suspicion, and always adopt an MDT approach in terms of not just management, but also diagnosis of issues with these women. These are some graphs just to highlight things of for women who came in. So about 10 out of the 10 women, 7 had previous surgeries, 3 didn't. And out of the 7 that had previous surgeries, 2 had laparoscopies because they had a frozen pelvis. And then we just did excision of endometriosis and ureterolysis for them previously. And then 2 women, interestingly, had subtotal abdominal hysterectomy around the age of late 30s. One was, I think, 38, and the other was in her 40s. And then these women were unfortunately started on unopposed estrogen only HRT. And they came in with cervical endometriomas that were there for quite some time, and then they caused ureteric obstruction, resulting in hydroureteral nephrosis, and loss of renal function, really. And 3 patients had laparotomies. I'll go into the details of why the laparotomies were. Now, I've mentioned it before, in literature, it says that about 80% of women who do present with endometriosis or ureteral endometriosis have it on the left side. Interestingly, we found it more common in our women who presented to us were about 6 women had it on the right side rather than the left. Now, these were my findings. Mean age of the women that came to us was about 36. So a few of the women were in their late 40s. A good chunk of them were in their 30s. 2 patients were actually in their late 20s. I think one was 27 and the other was 29. And if you can just appreciate the fact that women as young as this, in the prime, or supposed to be in the prime of their lives, have lost their kidneys to this disease. So the symptoms, all of them presented with chronic pelvic pain associated with dysmenorrhea, and 2 patients came in with flank pain. The laparotomy surgery, 2 had transverse incisions. One had a midline, 1 patient had a myomectomy. Out of these laparotomies, the patients the reason why they had it was myomectomy. 1 had a salpingectomy and drainage of an ovarian cyst, which was an endometrioma, sorry. And 2 had subtotal hysterectomies, 2 had laparoscopies, and interestingly, 3 patients didn't have any surgeries, so no prior issues. 2 patients had, so about 5 patients had previous triggers. So 2 patients had previous PID and 5 had endometriomas, out of which 2 of them also had PID. So these were the total cohort was 5, and 2 of them had endometrioma as well as PID. And 5 of them had an incidental finding. And when I say incidental finding, the incidental finding was not just the ureteric obstruction, it was also, so I think 1 patient had endometrioma and 1 patient had severe adhesions, rectovaginal endometriosis. Interestingly, the renal function was normal in 6 women and grossly deranged in 4. 6 women had deep infiltrative endometriosis on the bowel, rectovaginal wall, and 4 didn't. Mean duration of symptoms that we picked up was about 52 to 54 months. That was a duration that these women were struggling with before they were referred. Diagnosis, again, I cannot emphasize enough about strong clinical suspicion, and I appreciate that it will be difficult, but I just wanted to highlight in which patients you need to have a strong clinical suspicion. Again, I'm not saying do a routine renal scan or MRI looking at kidneys or ureters in every patient, but justify the means to the end of the investigations, really. Again, history, look for signs and symptoms, flank pain, dyspareunia to look for deep infiltrative endometriosis. Physical examination, you might pick up endometriotic nodules in the rectovaginal septum, masses, you might pick up endometriomas, frozen pelvis. Unexplained hypertension and silent renal failure may also occur in patients who've been running asymptomatic for a long time, bearing in mind that you need to lose about, that you need to have you need to lose about over 50% of your renal function in both the kidneys to become symptomatic. So by then it's late. Investigations that we went on with for these poor souls, obviously renal function tests, looking for the Usenes, looking for creatinine clearance, looking for EGFR, transvaginal scans, just to look for pelvic lesions like endometriosis, fibroids, abdominal pelvic ultrasound scans, very important, again, to look for ureters, look at kidneys, just a provisional examination. MRIs, and I'm sure Dr. Kirk has, mentioned it too in her presentation, how important this particular modality of imaging is in terms of further management. So the initial diagnosis, you can pick up hydroureteral nephrosis with an ultrasound scan, but further management in terms of extent of the disease is MRI. The women who had grossly deranged renal functions went on to have a MAG3 to see how much of their kidneys were actually functioning, and the reason for that is to manage or to plan ahead. And by plan I mean surgery. And should we adopt a conservative approach? Should we go for a surgery? Can we do a reimplantation? Should we do a nephrectomy? Mr. Williams will go into more details about these things. Yeah. Again, management, MDT, imperative, because we can't do everything. We shouldn't be expected to do everything. Every different surgeon has a different skill set in order to manage. And I think if all of these skill sets are combined, then I think we can approach, we can manage the patient in a better fashion. Now, if the disease is again intrinsic, and we've come across this numerous times, that if there is no obvious pathology that you can see, no gross hydronephrosis or no gross hydroureter or hydronephrosis, and if you pick it up on a laparoscopy or even on an ultrasound scan or an MRI, then you can, depending on the surgical expertise of the gynecologist and depending upon the experience and which unit you are working, you may be able to do ureterolysis, plus or minus with stenting. However, if the ureter is infiltrated, if it's an intrinsic disease, and then we would definitely suggest go with your urologist buddy, go with your team, plan out the surgery, see how much needs to be done or how little can be done, and essentially, yes, going in and approaching it via an MDT, because you might need a ureteral neocystostomy, you might need ureteral anastomosis, and the plan is different for every patient depending upon where the lesion is and the extent. Types of management interventions that we did for our women. So 3 of the women had ureterolysis, and the reason for that is because, unfortunately, one of their kidneys was beyond salvageable, whereas the other one was functioning well, and there was quite a lot of adhesions around, periureteric adhesions around the other kidney. So we released that, and we did it in conjunction with our urologists after we'd had an MDT review of these patients, and this is what was recommended, to say at this point this is what would be the best, and these women are awaiting nephrectomies. 4 women had stents, 1 had a reimplantation, 1 had a nephrectomy, 2 are being managed conservatively simply because their renal functions are normal, and unfortunately because of the pandemic, because of the huge backlog, and because of cancer patients waiting, we are unable to provide these women with nephrectomies. However, having said that, these women are coming to our clinics and even being followed up by the urologists every 6 months, some women annually, to check their renal function test, to do their what do you call renal kidney scans, just to make sure and assess if the disease has gotten any further, and if there is any further involvement of the other kidney. Because the most important aspect and the most important reason for doing all of this is the fact that these are young women. They've already lost a kidney. We need to make sure that their other kidney, nothing affects their other kidney, and things are managed. And even for the women who we are managing conservatively, they are on hormonal suppressants. Some of them are on GnRH analogs, others are on either norethistron or the mini pill, just to make sure that they don't have flare-ups. Thank you very much. That is my presentation. I'll stop sharing now. Simon?